Welcome to another episode of Cincinnati Cancer Advisors Medical Minute, brought to you by Kroger Health. I'm Andy Guinigundo, the Director of Precision Oncology here at CCA. Today we continue our ongoing series, ASCO Direct, a Patient Perspective. And it's an ongoing series discussing the latest and greatest out of ASCO 2023. I am joined by CCA's own Dr. Jazieh. Welcome, Dr. Jazieh.
Thank you. Thank you, Andy.
Yes. I am also joined by our colleague, Dr. Ramaswamy Govindan, who is the Associate Chief of Oncology, the Anheuser-Busch Chair of Medical Oncology, and the Associate Director of Translational Research at the Alvin J. Siteman Cancer Center at Washington University School of Medicine in St. Louis, Missouri. Welcome, Doctor.
Thank you so much. Thank you for having me.
Great. So today's episode is a little bit different. Our approach, all the episodes in this series have really focused around a particular cancer, breast cancer, lung cancer, melanoma. But today we're actually talking about precision oncology, which is kind of a concept. Dr. Jazieh, how would you define what precision oncology is?
Yeah, this is very important concept now, and a lot of news that, comes, from the scientific societies and communities. Basically, is trying to select the best treatment for a particular patients, for a particular disease, based on information that we obtain from testing the disease and the genetic of the patients, to select the best treatment for that, based on this information that we are collecting. So it's like a personalized medicine based on more information that we get from knowing more about the profile of the tumor. Of the patients.
No, I always feel like from a patient standpoint that in a way it's more understandable. It's not like, okay, you have this stage of breast cancer, you get drug X. Well, and take it or leave it, was what you get. But really, when you talk about precision oncology, precision medicine, I feel like because your cancer has this characteristic or this gene change, that we're going to give you this specific drug because of those changes. In a way, that's even more understandable for patients. So,
but as you will hear probably from our guests, there are different aspects also to precision medicine besides cancer treatment.
Yeah. So let's bring our guest here. So, Dr. Govindan, what does our audience need to know about precision medicine, do you think?
It's a great discussion, and I agree with the earlier points. One of the things that I would say that good clinicians have always practiced some personalized medicine from time immemorial. For example, if you have somebody with advanced lung cancer or breast cancer, had kidney function, we gave certain drugs. We didn't give certain drugs. So we tailored the dose. We adjusted from 2 drugs to 1 drug. So we always did some personalization of medical therapies. But what we have become better and better at, it's being a little bit more precise about it. We have come to appreciate that cancers that seemingly look the same radiographically or under microscope are virtually different diseases under one broad umbrella. True for breast cancer, true for lung cancer, true for many other cancers too. And EGFR mutant lung adenocarcinoma does not look that different than ALK positive or RET-driven cancer, but we approach them very differently. So that's where I think understanding the biology and going after that specific alterations, and that can be either by one of 2 ways currently, as we are thinking. After all, cancer is a disease of the genes, cellular genes that are dysregulated. So if you go after the key genetic alterations that we call targeted therapies, like EGFR mutant lung cancer, KRAS mutant cancers, etc., HER2 positive breast cancers. And the other approach is, as the cancer cells grow, the immune system tries to keep a lid on this and try to eliminate that. But the cancer cells find a way to beat the immune system by upregulating some molecules that make the immune cells exhausted and look the other way. And going after specifically using the specific immune therapies is a form of a personalized treatment. If you have time towards the end, we'll talk about where the immunotherapy is going to get personalized. But that's one way we are now doing it, going after PD-L1. And the coming years, we'll see many more checkpoints and other kind of immune therapies, and they'll be very personalized too. So I think we are getting to the era of understanding the biology, going after what drove the cancer or what made the cancer escape the immune system's careful surveillance.
Yeah, that is so true. To the patient, it almost sounds a lot like alphabet soup. But when somebody advances with so much breaking news, it seems like, and especially a time like around ASCO meeting, it's almost like you turn on the evening news, and every press release is being read by the nightly news. What should patients take seriously, or what should they pursue further based on their cancer themselves?
Yeah, it is actually quite overwhelming. There was a time when we did not have medical advances happening that fast. We did not have the media spreading that information that fast. Now the two factors are coming together. And the information age, we are living a flat information age. Imagine 25 years ago, if you're a patient wanted to know more about a cancer or a disease, you have to go to a public library, if you're a lay person. And now you're at the fingertip, you can cite the papers, and even the physicians may not be aware of, or they can be part of a phase group support group and they can get more information. And if you've really been taking care of those patients who are part of the support groups, they're very savvy. They understand what trials are ongoing. They come and talk to you about the trial that sometimes you as a physician may not be even aware of. And so what we need to really, there is unfortunately the perception that the latest is the better thing or the best thing. That's not true in medicine. We all know who have practiced long enough. And we learn, out of 10 drugs we try to evaluate, one of them eventually make it to the clinical practice. So our failure rates are pretty high. And we as physicians, scientists, and investigators have to be very cautious about overhyping. And I think I really like the topic you outlined. And for patients who are really anxious and families who truly are quite desperate, understandably so, every bit of this information may seem like a positive thing. And many times my patients ask me, why can't I get off the current therapy and go on this trial that seems promising when the current one is working? So it does take a bit of education to tell them why we are doing what we are doing now. So I think it's our responsibility to make sure that we put things in perspective and not hype every single thing as a latest breakthrough when we have marginally improved outcomes of a few patients' lives. And I think the responsibility lies with us, and media has some role to play here too.
So, are there any keywords that the patient should pay attention that this is something important to, like an endpoint, what we call it in our medical terms? Are there any catchy phrases that the patient should say, okay, that's important, that that's meaningful study for me? And if you can also give us an example from these studies from ASCO last ASCO meeting, please.
Absolutely. Again, depends on the level of involvement and engagement of the patients with what is going on. There are some patients physically and mentally are so devastated that they won't be able to pay attention to that. But there are some who are really want to know every single thing that happens. So to that audience, I would say you have to relook at the study and say whether it came from, is it pertinent to you? For example, if it's an EGFR mutant patient, you had an early stage lung cancer at resection, complete resection. And one of the things that you may want, for example, is the ADORA study that was presented at the ASCO meeting. And so that study is relevant. Why? Because it is a large study, phase 3 study, compared that with the existing standard, and then had reasonable follow-up. And so I think we don't want to turn our patients into statisticians or clinical trialists, but the key thing is to look for, is that relevant to your disease? Not just any lung cancer or any breast cancer. Is it relevant to your type of cancer that you have? Second, is this being studied in a fairly large numbers of patients? Although in some instances, the disease is so rare that getting 100 patients is a big achievement, like RET or ROS and those kind of lung cancers. And but for most part, you want to have larger numbers. Ideally, a phase 3 study would be something that you may want to pay attention to. And the fourth important thing is that significant, both statistically and clinically, as what the experts talk about. And so I think not every new study, not every new compound, especially you have to be careful about the early phase studies that have only few patients and that are sometimes, prominently displayed, I would say, that something may or may not pan out to be true. So larger, more mature studies relevant to your cancer, done by ideally international groups, national groups, and multi-center studies are the ones that one want to pay attention to. And the others, I would say that you don't have to dismiss them off completely, but those are the things my advice to our patients is very simple and straightforward. If something catches your attention, write them down, bring it up, the office visit, or if it's urgent, call us. And then please have an open mind. The answers would invariably be no, we are not doing that for these reasons, not not, we forgot about it, or we didn't know about it. It's often, you're doing well, this is why we are doing this, or that's too early, or that's not applicable to you. So if patients come with a preconceived idea that that's what I want to get based on some preconceived ideas, and the physician pushes back, then there could be some unnecessary angst over this, which probably was not necessary in the first place. That's my simple advice. That take it to your doctors. And they always say in the TV news, talk to your doctor, or the ads, they say, talk to your physician. And that's an overplayed thing. But then there is some truth to that. That have an open mind, bring up this. I always tell my patients, if you don't ask me, who would you ask? Not your plumber or your dry cleaner. So you got to ask me. And so ask those questions, but be prepared to say here that that's not applicable to you.
So you already touched upon some of the hurdles of not being able to implement or give the patient the treatment that he heard of or he got from the news and so on. So can you expand a little bit of what will be the challenges of implementing, or what are the reasons that the physician may not be able to give the treatment to that patient?
Terrific question. Great question. There are many reasons. Number one is the patients may be currently on a therapy. And I have a wonderful gentleman who is absolutely sweet and adorable, and he always brings up something each visit while he's doing very well on current therapy. The important thing is that even though the new therapy may seem more attractive, it is not guaranteed to work in everyone. So if something is working, you don't want to stop. You want to get the maximum out of that before we go on to something else, unless that something else has a very different profile, less side effects, and has dramatic differences. Then we realize that standard of care has changed so much that we are going to now offer everybody, interrupt what we do. And that happens very rarely. Most of the time, in advanced disease cancers, our goal is to control the disease. There you continue what's working, and then move on only when there is a need for that. And the second thing is, I always tell patients that the cancer cells find ways to escape the action of a particular drug, and they become resistant to current therapies. And we want to be careful and not leave things on the table without extracting the full benefit of a current regimen. And that's one important reason. The second reason is, in my view, that many of these drugs are available only when they're talked about, not yet approved, and they're available as a part of a clinical trial. Even if you have the clinical trial at your site, it is one of the requirements of almost all clinical trials I'm aware of is the current therapy should have stopped working. There should be evidence of disease progression before you can go on for good reasons, or must have intolerable toxicities on the current therapy. So a good number of our patients would not meet the criteria when they bring up these issues. If they really are progressing or have side effects, physicians would have brought them up more often than not. But those are two common reasons why you cannot change therapies.
Doctor, we're seeing a shift more towards trials that are what are described as tumor agnostic. In the past, we've done, okay, we're going to use this drug for this cancer, this drug for lung cancer, this drug for breast cancer. And now we're seeing more studies where you have a particular marker and doesn't matter the cancer, we have a particular marker. Can you comment on that trend?
Oh, absolutely. I think there was a lot of interest early on that, we will have not lung cancer, breast cancer clinic. We will have a KRAS clinic. We'll have EGFR clinic. We'll have HER2 clinic. I don't think, in my personal view, I could be wrong. I don't think that's going to happen. I think the diseases would stay disease-based. And while what is fascinating is that a given gene alteration may be a known driver in many cancers, but a response to targeting that gene would vary differently, significantly. And a great example is KRAS. KRAS G12C is one of the most common mutations. And when we have the isoform specific inhibitors, and in fact, we did the first trials, I've been very involved in that development of sotorasib, we saw nice responses in lung cancer and excellent disease control, 35 to 40% response rates. But the response rates in colorectal cancer was in less than single digit or very few responders. Both are the same KRAS G12C, the mechanisms are the same. And I think what happens is that, and we have begun to appreciate that as we study more and more the genomic alterations, the KRAS may be the initiating factor, but then you need subsequent tumor suppressor loss and other alterations to convert this early event, transforming event to a full-blown cancer. And that varies. That path the cancer cells take varied significantly from a lung cancer to colorectal cancer. These concurrent alterations perhaps significantly influence the response to therapies. And we need to understand that a lot better. But the KRAS is a great example why this agnostic thing may not work out. It would work out in some instances, like RET, and that's RET targeted therapies work across various cancers. Tumor microsatellite instability, MSI, would work across various cancers. There'll be some exceptions to that, but it won't be that simple to have one gene, one drug for all cancers. That requires a better understanding of what we need to combine for different cancer types.
Yeah, thank you, Dr. Govindan. So you mentioned the ADORA study. If there is any other studies at ASCO that worth mentioning as example of precision medicine success?
Yeah, one thing I was going to say is the Keynote 789, since we're talking about precision therapies, and as you know, all these EGFR inhibitors stop working after a while, whether it is the first, second, third generation. And then what happens, many of these patients get chemotherapy, immunotherapy in some combination, some order. And there was a study, my good friend James Yang presented, the Keynote 789 study, where nearly 500 patients with EGFR mutant lung cancer post-progression with EGFR TKI, including osimertinib, in many instances, got randomized to chemotherapy. Most of them get PEM-carbo, like the way we do here, and placebo, or PEM-carbo with pembrolizumab. If you look at that, this is an interesting study because in the practice, we often struggle with what to do. And two interesting points. Numerically, the numbers look a little better for pembro combination, but it really didn't meet the significant threshold. And the differences are marginal in my view, and it really didn't meet the statistical significance for overall survival and progression-free survival. So, and the interesting thing is the toxicities, I thought would be pretty high in the pembro arm because those coming off the EGFR TKI may end up having some toxicities when you throw in pembro right away together, but did not appear to be that much different. But I do think the reverse is very important. When somebody gets pembrolizumab or durvalumab, and then we suddenly start them on EGFR TKI inhibitors in EGFR mutant patients from stage 3 to stage 4, I do think there's a real risk of pneumonitis in a good number of these patients. You have to I usually give a window of 2 to 3 months after checkpoint blockade to start EGFR TKI inhibitors. But the other way around seem to be okay. But the bottom line is, I think we have options. You could add pembro to chemotherapy, especially the PD-L1 high numbers may help, but then this group doesn't benefit that much from pembro. So I usually give only pemetrexed and carbo when EGFR mutant patients progress on osimertinib, typically PEM-carbo, and then use pembro or some immunotherapy later on. I think that's an important study, even though it's a bit in the negative sense. It provides some clarity for practice.
Great. Wow. So much to think about, so much to consider. I really think that this discussion is a to be continued kind of discussion. So I, look for future episodes really, because this is not something that's going away. So thanks for joining us for this episode of Cincinnati Cancer Advisors Medical Minute, brought to you by Kroger Health. And we'll see you next time. for the next episode.